to my channel. My name is Abdrazak. In today's video we shall be looking at the pharmacology of drugs used in emesis, stroke vomiting. To begin with, what does vomiting mean? This is the forceful expulsion of gastric contents through the mouth. Vomiting may be due to the following causes. The first is adverse effects from medication, systemic disorders or infection. It can be due to pregnancy, vestibular dysfunction, central nervous system infection, or increased pressure. It can also be due to peritonitis, hepatobiliary disorders, GIT obstruction, dysmotility or infection. Lastly, it can be due to radiation or chemotherapy. In this slide is trying to show us there are mainly four sources of input to the vomiting center. The first one can be from the vestibular system, and in the vestibular system we have the H1 receptors and M1 receptors. Second, it can be due from the central nervous system, that is the cortex, thalamus, hypothalamus, so it can also be from the meninges. Another source, it can be due to it can be from the gastrointestinal tract and the heart. There we find most of the 5-HT receptors. And lastly, it can be due from the chemoreceptor trigger zone. There we find the D2 receptors, NK1 receptors, and 5-HT3 receptors. In this slide, we shall be looking at the pathophysiology of vomiting. Vomiting can be due to ingestion of a toxin, seeing something repulsive, or motion sickness can also lead to vomiting. So there are four sources. Of afferent input to the vomiting center. One being the chemoreceptor trigger zone in the area postrema. This is outside the blood-brain barrier, and in the CTZ zone, it is rich in the dopamine receptors, that is D2, in the serotonin receptors, that is the 5-HT3 receptors, and the neurokinin 1, NK1 receptors, and opioid receptors. It is connected to the emetic center via the nucleus of tractus solitarius. The second source is the vestibular system, and this is important in motion sickness via the cranial nerve 8. We've seen earlier it is rich in muscarinic and histamine H1 receptors. The third source is the vagal and spinal afferent nerves from the GIT. Here mainly we find the 5-HT3 receptors, that is the serotonin receptors. Lastly, the fourth source is from the central nervous system. It can be from the cortex or the thalamus, and this plays a role in vomiting due to psychiatric disorders, stress, and anticipatory vomiting prior to cancer chemotherapy. In this slide is trying to summarize what we have seen, that there are mainly four sources of input to the vomiting center. It can be from the cerebral cortex, where we have the anticipatory emesis, seeing, smelling, and thought of it can lead to vomiting. Cancer chemotherapy and the opioids, they can also stimulate the chemoreceptor trigger zone, leading to vomiting. Another source, we saw the vestibular nucleus as the vestibular system, which is important in the motion sickness. Another thing we saw from the GIT and the pharynx, there are some drugs which can irritate the GIT and can lead to vomiting. In this slide, we shall be looking at the classification of emetic drugs. And here it is trying to show us the class, the neurotransmitter, the receptor, and the examples of the drugs. So there are those we call the serotonin receptor antagonists, which act via mainly the 5-HT3 receptors. Here we have three: the ondansetron, granisetron, and dolasetron. We have the dopamine receptor antagonists, which act on D2 receptors. We have the metoclopramide and domperidone. We have the antihistamines, which act on the H1 receptors. We have the promethazine, we have meclizine and diphenhydramine. We have the anticholinergics, which act mainly on the M1 receptors. Here we have scopolamine or hyoscine. We also have neurokinin receptor antagonists, which act on the NK1 receptors. We have apriptant. Then lastly, we have the benzodiazepines, which act on the GABA receptors. Here we have the lorazepam and diazepam. Lastly, there are some other anti-emetic agents. They can be the cannabinoids. Here we have nabilone and dronabilone. We can have also the corticosteroids. Here, the main examples being dexamethasone and methylprednisolone. We can have the phenothiazines, that is the prochlorperazine. Also, we can have the promethazine being under here. We can have the butyrphenones, an example, of course, being the droperidol. Then lastly, we can have the substituted benzamides like the metoclopramide. Thanks for listening. Don't forget to subscribe.